Good morning, colleagues from all over the world, and welcome to the webinar today dealing with diagnosis and treatment of early infection. My name is Olivier Borens. I'm an orthopedic trauma surgeon and specialist for infections as well in Lausanne in Switzerland, and together with me, unfortunately not next to me, but in Berlin, is Andrew Trampus, an ID specialist who works at the Charité in Berlin and who's going to answer your questions on the net as well. And talking about questions, please do send us as many questions as possible during the entire talk. Andre Trampus is going to answer a couple of them directly while I will giving the talk. At the same time, we will have a session with questions and answers where we are going to answer as many of your questions as possible at the end of this webinar. So I think now we are going to start with this important subject, and once again, please do not hesitate to send your answers, your questions. During this meeting, what are we going to plan, or what are we going to talk about? We have different learning outcomes. We want to learn to recognize the possibility and the subtle signs of early infection after osteosynthesis. We want to talk about the etiology and the prevention of infection after a fracture, what different ways of diagnosing we are having and we can use, and what are modern tools of making the diagnosis. And finally, we want to discuss antibiotics and the combination of local antibiotics, systemic antibiotics, and surgery. Let's start with a question. This is a case that I saw a couple of weeks ago, a patient that had been operated on 4 weeks before during his vacation in France. As you can see, it was a Weber C fracture that was operated on with this plate. The patient presented 10 days after the operation at our hospital with this foot. As you can see, there's a lateral incision, and in the distal part of the lateral incision, there is now a wound dehiscence. And my question to you is, what would you do in a situation like this? Would you wait? Would you go for further exams? Like a CT scan, MRI, maybe even scintigraphy? Would you operate directly on the patient? Would you start antibiotics, or would you operate and give antibiotics? So I'm very interested in seeing what your opinion is, what you would do. So maybe we can look now at your results, what you decided. So the results, which the poll is closed now for voting, and we can see. And very interestingly, the most of you would go for further exams. The second part of you would wait, and others would start with antibiotics. So it's more or less the same. Not very many of you would operate straight away. So let's go on with the same patient, because we went for further exams. And with a probe now, we have a direct contact with the plate in the lower part of the wound. Around here, there's a direct contact with the plate and with the bone. So in this situation now, would you still wait, or what would you do? Please give me your answer now. What would you suggest in this situation? Okay. It's just another, okay. So what we can see now, after having closed the poll, it is that most of us would go now for surgery and antibiotics, and this is exactly actually what we did. We said that now there is a problem with wound healing, the plate is exposed, and now unfortunately we cannot wait for it to heal, because it's probably not going to close with the infection. And at the same time, there is no need to do further exams, because we are sure now that there is actually an infection happening. This is what we all want to do. This is what we all love to do. And normally, most of the time, we have very happy endings. We are having good results. But we must bear in mind that about 5% of our surgeries are going to get infected. We know that in open fractures of the tibia, this can go up to 40%, but more or less 5% of our osteosynthesis is going to be infected. Why does it happen? Why is this nemesis of every surgeon happening? And for us, of course, it is a catastrophe to have an infection. And it is always difficult when our patient that has been operated on for a fracture of his lateral malleolus comes back to our outpatients clinics and he says, "Hey doctor, my ankle is red and painful. It's getting even worse." When the patient tells us, "Hey, my physiotherapist told me that there might be an infection," or when a colleague of ours tells us, "Hey, I saw your patient while you were away on vacation or on a meeting, and the leg doesn't look very good." What can we do in a situation like this? Of course, we can tell our patient, "Hey, no problem. Everything is going to be fine. The infection, there is no infection. I've never had an infection." We can tell ourselves, "No, this is impossible. I've done everything that was supposed to be done in order to prevent infection, so it's not possible." We can call up the physiotherapist and tell him to mind his own business. Of course, we can start the patient with antibiotics, but this is probably not going to help us. Or we can look for an explanation in diagnosis. So I'm sure that each one of you has his own idea on how to deal with this, but I think it is important for us to know that if we only reassure the patient and tell him that there is no problem, or if we only reassure ourselves, or if we start antibiotics in this situation without knowing what's really going on, well, actually we are doing an ostrich behavior, so we're just hiding from the reality, because if there is redness after an osteosynthesis, if there are even subtle signs of an infection, we have to look for an explanation. We have to know why the wound is red. We have to go for a diagnosis in order to be able to help our patient and to have afterwards a good result for our patient. So if there's a suspected postoperative infection, one of the most important rules is to be self-critical. Infections do happen. It happens to everybody, and we have to be self-critical. We should not hide from the reality. And infections do happen to everybody of us, and the more we operate, the more infections we are going to have. But an infection by itself is not really a huge catastrophe, because if we deal correctly with the infection, if we take the patient to the OR, if we clean out the wound, if we give good antibiotics, if we do good soft tissue coverage, actually it is almost one of the best complications there is, because there are pretty easy ways of getting to deal with this infection and getting rid of the infection. So it's very important to be honest and to start dealing quickly with the infection in order not to have too much biofilm growing on our implant. What is biofilm, or why are our foreign bodies, our implants which we are putting in our patients, getting infected anyway? Well, the problem of the implants we are using, whether it's now orthopedic implants, but it's the same with the breast implants, with vascular implants, it's that implants are devoid of microcirculation. As they are devoid of microcirculation, they have no host defense. They cannot defend themselves against bacteria. The problem is that most of the implants which we are still using today, they are not covered with antibiotics or antiseptics, so there's no host defense. At the same time, there's no antibiotic delivery directly on the implant, and the risk of infection is high. This has been shown many years ago, where they used to foreign bodies subcutaneously, and they looked at how much more inoculum it was needed to provoke an infection subcutaneously in healthy med students. And they put in a little a little foreign body under the forearm of med students, and they saw that it needed 100,000 times less bacteria to provoke an infection if there was a foreign body than if there was none. So the foreign body itself is already increasing the risk of having an infection. And the infection is normally generated initially by bacteria, which are free swimming, which are called planktonic bacteria. But then, as soon as they go on the plate, they do start producing a so-called biofilm. The biofilm is a mechanism of the microbes to survive in unfavorable environment. They can survive even if there's a lack of nutrition, even if there are antibiotics, and even if the host immune system is active. They are protected in jail, in a slime in which they are metabolically inactive, and our antibiotics cannot attack them. How does this look, and how fast does it go? It goes very quickly. The biofilm is the so-called race for the surface. That happens pretty quickly, as you can see here. At the beginning, we have free floating bacteria. They are planktonic. Then they go on our plate. They start producing this slime, the biofilm, and producing this biofilm, they're getting already after a couple of hours rather well protected. And over the days, here at the end, after 3 days, they have like a multicellular organism where they even can speak with each other, which is called quorum sensing. They know when there are antibiotics coming in, they know when they are being attacked, and so they can really protect themselves. And from time to time, as you can see here, there are a couple of germs that are becoming planktonic again, and they swim away or they go away, and they can infect another implant, or they can provoke a systemic infection. So the biofilm is a major issue. It's a huge problem for us, and we see that the biofilm is growing rather quickly, and once it's mature, it's very difficult, even with good antibiotics, to get rid of it. But why our patients are getting infected? So our patients, of course, is a risk factor by itself if we're starting to operate on them, and a couple of these risk factors can be influenced. So, of course, the host at the beginning is the patient with whom we have to try. We have to work. The patient, when he comes in with non-modifiable risk factors, which is normally the age, the severity of illness which he has, the severity of the lesion. We know that if there's an open fracture, of course, even if we do all the most important parts of a good prophylaxis of infection, we know that as a non-modifiable risk factor, the open fracture is going to increase the risk of having an infection and of having a problem. And then we have for every patient modifiable risk factors, which I'm going to show you just in a few seconds. The rule of thumb is that most of the people which we are dealing with, we can improve their general health and the way they are doing. If you look now at the modifiable risk factors, which you can see here on the left side of the screen, it's diabetes. So we know that if we are able to improve the diabetes of our patients to around 7, we know that we can decrease the risk of infection by a good, very importantly. Smoking is a major risk factor. Of course, in trauma, often we cannot tell our patients to stop smoking for a couple of weeks before the operation. So there we cannot have any influence, but we know that, for instance, if we are dealing with infected non-humans, then if we can get our patients to stop smoking before the operation, that there we can clearly decrease the risk of infection. Obesity is important. We have to look at how the nutritional status is in our patients. We have often in gerontotraumatology, in elderly patients, they are very often undernourished. So if we can improve their status, we know that we have a direct impact on diminishing the risk of infection. While there are these patient factors, we have, of course, factors during the operation. By the way, at the end of today's webinar, we are going to give you a link to a PDF which has been done by a working group on infections by the AO, where you can look at a checklist where are the most important things of what I'm saying right now are once again reproduced, which you can print out for your hospital and see what you're doing already perfectly correctly and which points you might improve. So what about the operation? Of course, the duration of surgical scrub is for the surgeon when we wash our hands. Often it's that the chief surgeon, he has his hands clean after 5 seconds, while the interns, they have to scrub them for 2 minutes. Ideally, it is at least 2 minutes of scrubbing in order to really have clean hands. We have to go for skin antisepsis. The preoperative shaving should be done just before the operation and should be limited only to where we are operating. So there is no sense if we do a shoulder operation with a deltopectoral approach to shave, for instance, in the armpit. There is no sense in doing that. And if we shave, we should do it just before the operation. We should not do it the night before. We should not do it on the ward because it has been shown that the contamination of the skin is going up if we shave it with a normal razor and if we shave it, for instance, the night before. Preoperative skin preparation is important. We have to first mechanically wash before we disinfect. Duration of the operation has an impact. The longer the operation lasts, the higher the risk of infection. During long operations, often patients do cool down, and if they are too cold, the risk of infection goes up. Antimicrobial prophylaxis is a very important point. That's the reason why we're going to talk more in detail about this subject afterwards. Ventilation is important, and we have to be sure that in our hospital, the way of sterilization of the instruments is followed very strictly, and it's regularly controlled by the surgeons as well. We have to look at surgical drains, at our surgical technique. Surgical technique is important. We know that the more of tissue trauma we are actually producing, the more of dead tissue we leave, the higher the infection risk is. And of course, poor hemostasis leads to a major hematoma, and the fact of having a hematoma leads to an increased risk of infection as well. And finally, of course, dead space management is important because the more dead space we have, the more hematoma we are going to have. So these are the important points where we can have an influence on the risk of the surgical site infection, and which we should check before when we operate our patients in order to decrease the risk. I've been talking about antimicrobial prophylaxis. So antimicrobial prophylaxis is important. Normally, every operation which we are doing where we are putting in foreign material should be combined with antibiotic prophylaxis. Normally, the ideal antibiotic prophylaxis is a first or a second generation cephalosporin. If we have a confirmed allergy to beta-lactams and antibiotics, clindamycin or vancomycin would be a good alternative. Vancomycin should be as well thought about in patients which are operated on in hospitals where there is an endemic presentation or presence of MRSA. So once again, cephalosporins are probably the best antibiotics to need as a prophylaxis for standard surgery. But there are lots of errors that are being committed while using perioperative antibiotic prophylaxis. On one hand side, it can be given too early. If we give it too early, we know that the effect is going to be less good. So antibiotics should not be given on the ward, but they should be given once the patient is in the operating theater. If we give the antibiotics too late, they are not going to be there when we are putting in our implants, so this increases the infection risk. There is no need to give too broad spectrum antibiotics because we really should focus on those which are the most likely to do an infection in a standard orthopedic trauma procedure. No need to give the antibiotics for longer than 24 hours. It has been shown that there is no additional help if we prolong our antibiotic prophylaxis, but we can have more complications due to the prolonged antibiotic prophylaxis. Too frequent, we should not use antibiotics in minor surgery. Minor surgery means only for putting in pins or an external fixator when there's no open fracture, or for instance, if we do a standard arthroscopy without putting in any implants, so there's normally no need for antibiotic prophylaxis. And of course, too few is when we don't need antibiotic prophylaxis in situations where we normally should have used it. When should we give our antibiotic prophylaxis? This is a very important point as well. As you can see on this slide here, this is a rather old paper where they looked at the infection rate compared to when the antibiotics were given. If you look here at the beginning, if you give the antibiotics too early, which means 2 hours and more before the operation, so mostly on the ward, the infection rate is much, much higher. If you give it 1 hour to 30 minutes before the operation, that's for the cephalosporins, this is probably the perfect, or this is the perfect moment. If you have to give vancomycin, you should give it at 1 hour before the incision, because the infusion time is just longer than with the cephalosporins. And here you can see that if you give the antibiotics too late, that means that you already have started the operation, then the infection risk is going up once again. So it is very important that you check with your anesthesiologist and yourself who is going to give the order on what time and what point to give the antibiotics. Well, now we are pretty sure there's an infection, but only knowing that there's an infection is just half of what we really need to know, because we need to know what germ it is, so we need to know our enemy to win the war. Because only if we know our enemy, we can really decide on which antibiotics to give and which treatment we are really going to be able to use. Of course, the diagnosis can be easy. If you have exposed plate, if you have, like you can see here, if you have a fistula with oozing pus, or even if you have here bone, exposed bone, at that time you know that there's an infection and the diagnosis is rather easy. But from time to time, it can be much more difficult, and you have to look for subtle signs, because from time to time, the normal 5 standard signs of infection, which are pain, swelling, warmth, redness, and bad function, cannot always be found in a patient. So we need to look for subtle signs, and a sound exam of our patient looking perfectly well at the wound from time to time helps us, because at that time we can make the diagnosis and we can see that there is something wrong. So we should always start with a normal, easy, and sound clinical examination before we go further on asking for more complex diagnostics. Which diagnostics methods do we know? Which diagnostics methods are we using? We have, of course, pre-operative ways of making the diagnosis or helping us to make the diagnosis of an infection. And we have intraoperative methods of making the diagnosis, and a couple of them are worth to be discussed. What about the laboratory evaluation? Sedimentation rate has unfortunately a low specificity, so normally we cannot really rely on the sedimentation rate. Leukocytes as well are not very discriminatory for the presence or absence of infection, and unfortunately we cannot really rely on this. The best way of looking whether there is an infection, if we only want to use laboratory evaluation, is the CRP. The CRP, although it stays elevated for a couple of days to weeks after the operation, is giving us a very good way of knowing whether there's an infection, especially if you look at the evolution at the kinetics of the CRP. If the CRP is elevated after the operation, but we see that it's always going down a little bit, we can be rather sure that there is no infection. But at the same time, if we see that the CRP, which is 20 after 1 week, is going up to 25, 30, 40, at that moment we should be worried that there might be an infection, and then we have, of course, to go further and make other diagnostics to confirm the infection in order to be able to make the good choice on how to deal with this infection. As you can see, there are other ways, there are other biomarkers as well, which are being used for calcitonin, interleukin-6, TNF-A alpha. They are, on one hand side, very expensive, but at the other hand side, as you can see on this slide here, they are not extremely helpful or much more sensitive than the CRP. The main advantage of interleukin-6 or TNF or PCT is that they are getting positive, or that they're rising quicker than the CRP. So they are helpful in making the diagnosis of an early infection if you need to know within a couple of hours. But most of the time in orthopedics, normally this time issue is not as important. That's the reason why the main biomarker which we are looking at, or we should be looking at, is the CRP, and probably our hospital finance director is going to be happy about that as well if we don't use too much procalcitonin and interleukin-6. What about imaging studies? Imaging studies, of course, are very helpful, but unfortunately there's today no single imaging study which can prove us with a high sensitivity and specificity that there is really an infection. In orthopedic trauma, we always need plain x-rays in order to look at the osteosynthesis which has been done. Of course, we have to look at bony changes. That's the reason why you have to look at the x-rays over time. Is there a changing in the bony structure? Is there an osteolysis? Is there a loosening of the plate or of the screws? This can be signs that there is something going on. If we have new subperiosteal bone growth, if we have transcortical sinus, this might be a very good sign for an infection. But of course, there are other reasons that might lead to lysis as well. So we cannot really only rely on x-rays, but they are extremely important for us to evaluate the stability of our construct. Scintigraphy, whether it's only with technetium labeled or whether it is made with multileukocytes, have a very high sensitivity, but unfortunately the specificity is low, and it's exactly the same for PET-CT. So if they are negative, it is very good to rule out the infection. If they are positive, unfortunately, we cannot be sure that there's really an infection present. Especially in early infection, normally imaging studies are not extremely helpful to make the diagnosis, because we're just going to see some reaction, but we cannot be sure that there is really an infection going on. What about CT scan? CT scan is mainly used to look at the soft tissue infection around the implant. We can see whether there's some implant losing or bony erosion. But once again, due to metallic artifacts, if we don't use Mars technique, the sensitivity here is good, but specificity, unfortunately, is not extremely good. And it's the same for MRI. And once again, MRI is used more frequently in longer-lasting chronic infections to look a little bit at the extent of the bony involvement, but in early infection normally it's not very helpful. Now, as I said before, it is of course extremely important to know if there's an infection, but we want to know as well what germ it is. So in order to know what germ it is, well, we have to get some tissue to send it to the lab for our microbiologists to examine. So if we take specimens, normally we should take at least 3 to 5 specimens. They should be taken at the interface between the implant and the soft tissues, they should not be taken in distance to the infection. If we take it very close to our implant, we increase the chance of finding really what's going on. We should not only go for one single biopsy, as it can be false positive. So at least 3 to 5 specimens, very important. And please do not take any swabs because the sensitivity is very low and it might be false negative. And at the same time, don't take tissue specimens from sinus tracts, as the sinus tracts, they risk to be false positive, which means they are risk to show you germs which are on the surface or in the sinus, but not those which are really on the plate and on the bone. So no swabs and no sinus tract cultures. Don't rely on gram staining. It has only a 50% sensitivity, and culture sensitivity is, even if we take good tissue specimens, only 60 to 80%. So even if it's negative, unfortunately, we cannot rely on that. In order to increase the sensitivity, what we can do is we can prolong the incubation time from 7 to 14 days. This is going to give us a chance of finding, for instance, P. acnes infections, mainly in shoulder surgery, because they just take much, much longer. These anaerobics take more time in order to grow. So we have to make sure that our microbiologist in his lab knows that we are looking for these germs in low-grade infections as well. At the same time, ideally in patients that have been under antibiotic treatment, the antibiotics should be stopped for 2 weeks before the operation, and we should delay surgical prophylaxis. The problem and the reason why our sensitivity is low if we do standard cultures is that with our standard cultures we are looking for planktonic bacteria, but most of the bacteria, they grow in a biofilm mode, and we are not able to really find these bacteria in biofilm mode if we don't use a new way of diagnosis, which is sonication. What is sonication? It is a way of giving us a much, much better chance of making the diagnosis of an infection. How does it work? We remove the implant. As you can see here, it's a total knee, but it can be a plate or a nail as well. We put it in one of these plastic boxes, which we are first vortexing, which is we're just mixing it after the implant has been covered with saline, and then we put it in this sonication machine, and we sonicate for 2 minutes. Here you can see down here on the left side, this is in the same patient, only with standard method with tissue, and here after sonication, how much better our chances are of finding the germ and making the diagnosis. Dr. Trampers has published widely on this, and he has shown that our chance of making the diagnosis are much better. How does it work? We have thus the sonication. We provoke in the sonicator mechanical vibrations. Those mechanical vibrations, they produce micro bubbles or cavitation. These micro bubbles, they arrive on the surface here of our implant and they implode. While they implode on the fixed surface, they generate a jet, and this jet breaks up the biofilm, and the bacteria become once again planktonic, and with this, as they are planktonic, we are going to be able to make the diagnosis of the infection. This has been shown in this paper in 2007, where 846 implants have been used. As you can see here, half joint prosthesis, or a little bit more than half fracture fixation devices. And here, thanks to the sonication, our sensitivity was much, much higher than with standard tissue cultures. It gets even more interesting if we use this technique in patients that have been treated already with antibiotics before. Normally, these antibiotics, if the patient is pre-treated, are killing the planktonic bacteria. That's why standard cultures are less sensitive. But they don't kill the biofilm bacteria, and this is the reason why if we use sonication, our chances of making the diagnosis are much, much better. Okay, now we know that there's an infection, we know that we have to do something, and one of the important rules is that the treatment of infection should always be combined surgical and pharmaceutical. If we only use antibiotics, as in this case here, so the patient has no surgery, we only use antibiotics, we can get the bacterial load down for about 2 logs, but after a certain time, it's going up and we're going to have resistant strains. If we combine our antibiotics now with debridement, in this case with an insufficient debridement, we can see that we get it down 2 or 3 logs more, but at the end, if the debridement was insufficient, it's not going to be, if it was not sufficient, we're not going to be able to eradicate. So we need to have, if we want to get completely rid of the infection, an extensive debridement, often combined with systemic and local antibiotics, in order to eradicate the infection. So surgery is always needed, and if we only do suppressive antibiotics, we are not going to get rid of the infection. So how, from the surgical point of view, what should we do? So the first rule, and I think these are modern surgical concepts, which, by the way, were described as well by Martin McNally from Oxford, is we have to have no fear. We have to do rapid and sufficient debridement. We have to cut out everything that looks infected, that is covered with pus and that doesn't look good. So we have no fear. We have to take away every material which is not stable. If from the radiological point of view or from the local point of view, we see that our osteosynthesis is not stable, we have to change this to another mode of fixation. This has been shown by Wimmerneger in the 70s, that without stability there is no healing of infection. In total joints, for instance, we must change the mobile parts if we want to keep the prosthesis, or in a situation where we can keep the rest of the prosthesis. So we should decrease the load of bacteria. We need to close the wound. We should not go for repeated washouts. Every new washout is going to increase the risk of superinfection, so we should debride as much as possible without fear and get the wound closed. If there is need for a soft tissue coverage by a plastic surgeon, we should not hesitate to call them right away while we are doing it, and we should really try to use the vacuum-assisted closure as rarely as possible and not for a prolonged time. So I think for a vac closure for 1 or 2 days or 3 days is okay, but then we need a plastic surgeon to cover our implants in order to decrease the risk of continuing of chronic infection. Important as well is if we are planning to do an operation on a patient where we know that there's an infection, we should not start giving him antibiotics a couple of days before. So the treatment here, if we have a stable implant, and that's more or less the rule, if we have a stable implant, debridement and retention of the material, long-term antibiotics until we can take out the implant. Repeated debridements should be avoided. If it's not possible to do it without repeated debridement, maybe we should take out the implant even if it's stable and go for another implant. And once again, we should take out the hardware as quickly as possible. If we have an unstable implant, then we need to debride and then change the implant, often to an external fixator. Today there are other ways as well of cement-coated nails or antibiotic-coated nails, but normally often external fixators are being used in these situations. We need long-term antibiotics as well, and of course, once again, removal of the hardware as quickly as possible. I cannot put enough emphasis on the importance of a plastic surgeon. If we are not able to cover the wound correctly by ourselves, we must not hesitate to get a plastic surgeon. And once again, all that tissue has to be taken away and it behaves as a foreign body. Antibiotics, very important. As you can see, these antibiotics are rather difficult to pronounce, to read, and there are many of them. There are some which are bacteriostatic, some which are bactericidal. Please do not hesitate to contact an ID specialist. Teamwork is very important because they need to help you. Systemic antibiotics are very good. Here you can see the different antibiotics which are on the market, which are really proven to be very helpful in orthopedic infection, whether it's in trauma or in joint replacement. And I'm sure that you can read this antibiotics once this talk is over, because you can have directly download the file of this presentation. But systemic antibiotics have a limitation. The limitations are that if we have a necrotic center of an infection and we have done a big debridement, vascularity can be difficult and our antibiotics cannot reach the site of infection. At the same time, from time to time, we do not have high enough doses of antibiotics locally, and we are not able to kill the antibiotics. That is the reason why we should use local antibiotics as well. If you see here, if we use systemic, we have it in the serum very high, urine very high, but not very good on the infection side. If you use it locally, we have it mainly on the infection side, where it's really helpful, and we can have up to 1,000 times higher concentrations if we use different ways of getting our local antibiotics to our patients. Which are these different ways of getting the antibiotics to our patients? We can use collagen sponges, and this is something which is very helpful. We have local delivery, it's easy to apply, it can even has a hemostatic effect as well. The problem is that from time to time it's difficult to get it into a diaphysis. We cannot choose the antibiotics we want to have in these fleeces. Normally it's gentamicin, and the delivery time is very short and there's no stability. And we can use PMMA beads, normally with gentamicin. They can even be homemade in hospitals where we cannot buy the prefabricated ones. They can be homemade. Normally the antibiotic delivery is very good, and we can take it out until 10 days after the operation very easily. The problem is that if we leave it in too long, at that time it can be difficult to get it out. The chains can break, they can rupture, and then we can have a very hard time to get out the last beads which are sticking in the bone, and of course they don't give any stability. So local antibiotic therapy is very important, as it helps us to on one hand side to deal with dead space, but at the same time we have very little systemic toxicity, even if we give rather high doses of gentamicin in our PMMA beads or in our cement spacers. We bring antibiotics to a devascularized area up to 1,000 times higher than if we give it only an IV. And if we use local antibiotics, we generally should use it with systemic antibiotics as well. So this was now part one of our talk. I tried to give you an overview of diagnostics antibiotics, and now I am happy to answer a couple of your questions. Let me see here the questions. There's one question from Greece, from Dr. Papakonstantinou. Are you using povidone iodine in contact with the subcutaneous tissues or deeper tissues? I'm not using it. Normally, we are only washing out the wounds with saline. There is actually no real need to use povidone iodine to wash out. It's the same with other disinfectants. The most important thing, I think, is the dilution. There's the saying, dilution is the solution to pollution. So it's mainly the mechanical washing of the soft tissues and the bone which is helping, and it's not so important to use different saline, different Castilian soap or iodine to wash out. And you must not forget that iodine can be cytotoxic as well, so we do not use it. Then we have this here. Then we have one question from Lion van Schot in Netherlands. What is the ideal time for revision surgery in relation to have the lowest possible risk of developing an infection? Given the situation, the wound is quiet, ASAP, or wait until the wound is healed after 2 to 3 weeks? That's a tough one. I really do think that it depends very much on the local situation. If you know that there's an infection, I think there's no sense in waiting for 2 to 3 weeks, because if there's an infection, the wound is not going to be very good anyway. So probably the best thing would be, or what we are trying to do, is if we know or if we see that there's a wound healing issue, if we see that, for instance, there's a prolonged oozing of the wound, or there's an opening of the wound, normally we take the patient back to the OR as quickly as possible. We do a washout, we clean, we check the implants, we're probably going to use a sponge or local antibiotics as well, and we start with the patient. And as I said, the longer you wait, the more time the biofilm is going to have to develop, and the more difficult it's going to be to get rid of the infection. So for me, the quicker the better. If you have a real infection, after 2 to 3 weeks, the wound and the soft tissues are not really going to improve, unless you give antibiotics before the operation. But as I said, I do not think that that's a very good idea. Then we are going to Ireland. There's Niak Poiko, who wants to know what dressings would you use in the interim between the settling of acute infection and the definitive flap application in the case where plate is still visible, and agree with systemic antibiotics. So what dressings would you use in the interim between acute infection and definitive flap? So in these situations, normally, as I said, I try to get my plastic surgeons to come and put the flap on during the same operation when I'm cleaning and debriding and changing the hardware if necessary. So ideally, they should do it during the same operation. If I have to wait for 1 or 2 days, I can do normal gauze, wet gauze dressing, or I can use a vac, but once again only for a very, very short time, in order to get the plastic surgeons to get ready to do the flap. So very, very short time, and normally standard gauze, wet gauze, or maybe a vac. Then we have a question from Bangladesh. What is the role of permanent iodine wash before closure of the surgery? So here again, I know that there are lots of different ways of dealing or of preventing infection. In Switzerland or in my hospital, and normally we do not do a providone iodine washout before we close. We only use saline to wash it out. Once again, it's a mechanical washout. We know that providone iodine is cytotoxic, and we don't use it in our hospital, and normally it has been proven not to really be of any advantage to our patients. It's the mechanical washout that is important, and normally to kill the bacteria, this is the antibiotics which are given or which have been given as a prophylactic drug. Then we go to Mexico, Luis. So in most cases, the vac system is not a good option. And for most of my colleagues, I do think that a vac is a very temporary solution. We have been able to show in a paper with Andrew Trampers that if you prolong vac therapy, standard vac therapy, normally what you have super infections, and you're getting more and more resistant bugs on the foam if you analyze the foam from the microbiological point of view. So normally it should be something which is really used only for a very, very short time, not more than 2 to 3 days, and then you have to cover. This is when you have an implant and bone exposed. from time to time, in situations where it's only superficial, where you're waiting to cover the skin, for instance, with skin graft, you can leave it on a little bit longer. But as soon as you have hardware or bone exposed, I think that prolonged back therapy is not good for your patient. And then we have a question here from Malaysia, Ashwini Sod. Do you believe in proactive débridement followed by bone transport instead of repeated débridement and antibiotics which can be very costly sometimes? That's a very good question. I think it depends very much on the local situation, so on the soft tissue condition, and at the same time on the bony situation. In many times, if we have a very bad soft tissue situation, or if we have if the bone situation is very bad, probably bone transport can be a good way of dealing with the infection, but it really depends on the situation. So it's difficult to give you a precise answer to that, just because it really depends on the situation. For me, what I've learned with the years is the most important thing in fractures, in infected fractures, is not that much the bone. The most important thing are the soft tissues. If you deal with the soft tissues and you can solve the problem with the soft tissues, at that time the bone issue becomes not such an important issue, and you can deal with the bone infection once you have dealt well with the soft tissues. And then we just go here to Argentina. Fabrizio Enrique Videla Avila. Always Vancogenta mixed with cement. Any other antibiotic options? So it has been shown that actually the combination of Vanco and Genta is probably best, because they are increasing the elution one to another, so they have a synergistic effect. Of course, there are other antibiotics which can be used as well. In our hospital, we use tobramycin, gentamicin, and vancomycin. We don't use any other ones. If you want to use another one, you have to be sure that it is heat stable, so that it does not naturate when the cement is getting 80 degrees warm, and that it's hydrophilic, because they are antibiotics which are hydrophobic, and then there's no elution of the antibiotics out of the cement. There's a very good paper by Chu in the Journal of Bone and Joint Surgery America, 2004, where there is a resume of the antibiotics which can be used and in which cement. So for us, normally Vancogenta is perfect. Something which is very important, we have not been talking about one of the important anti-biofilm drugs, which is rifampin. You should not use rifampin in cement, because if you use rifampin in cement, the cement is never going to harden out, or it's going to take more than 24 hours to harden out. And if you use a spacer oil, you probably do not want to wait that long. So no rifampin in the cement. And here from Egypt, what is your, Mohammed Al-Bakari, what is your experience about induced membrane technique in the treatment of infection? So in this topic today, we were talking about acute infection and not infected non-unions or big bone deficits. Induced membrane technique is something which is very helpful. Normally the rule now is if you use it, the induced membrane muscular technique, normally the defect should not be more than 5 centimeters in the diaphysis. If it's more than 5 centimeters, it's probably better to use a bone transport. But if you use it in less than 5 centimeters, we are using it quite a lot. We are using it with the RIA system in order to get enough bone to fill up afterwards our induced membrane, the bone defect, and at the same time, what we're doing, we are mixing the bone with bone alive in order, which is bioglass, and this bioglass is like lighting up a little bit our graft, and we have very good results with that. So we like to use the induced membrane technique as well if the deficit is less than 5 centimeters. Then we have a question from Pakistan, and Mohammed Rafat. Is there a role of an intramedullary continuous irrigation after infected intramedullary nerve removal? Any experience and comment? It was for a long time a well-described technique. For us, we do not need it, and we don't use it at all, because we do think that we are creating superhighways, and it has been described, as well as continuous irrigation in septic arthritis, for instance. We know that after a certain time, the liquid is going from proximal to distal, and we are not really irrigating the entire femoral cavity. The other problem is that there's an increased risk of producing a superinfection because there's a way of germs to get in. So it's a little bit, in our opinion, a risky procedure, although there are people, especially Professor Lautenbach from South Africa, advocating this technique, but we do not use it at all because we think it's dangerous for the patient, and we'd rather fill up the cavity of our patient with a cement nail, which is loaded with antibiotics in order to do the dead space management and to help our patient. Okay, I think we can go for one last question. Unfortunately, we're going to answer more questions afterwards, but here is one last question, which is from India, Raful Herode. Is there any guideline for identifying questionable tissue during debridement? There's actually no real guideline. There are now different ways of making the diagnosis of an infection. Of course, we know that the fresh frozen sections are being used. It depends very much, unfortunately, on the quality of your pathologist in order to find the infection and what's really going on. In our hospital, unfortunately, the pathologist is not good enough to do that, so we don't use that. Another way now is there are new biomarkers on the market, for instance, the alpha-defensin, which should give us a chance, if there's some liquids, to see whether there's an infection, and we should normally know the result within 10 minutes. And then there are PCR, so polymerase chain reaction devices, which are going to give us an answer within 10 minutes. But unfortunately, there is no good way today of being 100% sure that in the debridement, what you're really taking away, whether it's infected or not. And as I said before, what we're mostly using is the gram stain. Unfortunately, gram staining is only comes only with a 50% sensitivity. Specificity is good, but sensitivity, unfortunately, is bad. So I think we have to go on, unfortunately, to the next couple of slides. So if we have an acute postoperative infection, we have 4 goals. We want to control the infection. We want to have a good soft tissue management. Initially, we want to try and keep the implant, but if we see that we cannot control the implant with keeping, we cannot control the infection by keeping the implant, but we just have to take it out. So we must not hesitate taking the implant out and finding another way of controlling the reduction. And of course, what we want to do as well is we want to prevent chronic infection. The take-home message of today's webinar are the first thing I think is we have to learn to be self-critical. Infections do happen. It's not a catastrophe if it happens. We should start with easy diagnostics, which are going to help us afterwards to do the good choices for the treatment. Infection treatment is always a team effort between surgeon, ID specialist, microbiologist, plastic surgeon, and often we need an internal doctor as well, especially in diabetic patients, for instance. And the treatment is normally, surgery is always needed. You cannot get rid of an infection only with antibiotics, and we should combine local and systemic antibiotics if possible in order to have a good result. So this is almost the end, and we are going, Dr. Tramples and myself, we are going to continue answering as many questions as possible now on the net. And please do not forget now that you can download a PDF file on prevention of infection that has been prepared by the AO working group on infections. And with this, I thank you very much for your attention, and I spent a wonderful hour with all of you. Thank you very much.